I got one yesterday too.
Hi, everyone. Welcome to our webinar today. We'll start in about 3 minutes just to make sure everyone can get on. All right, well, it is 5 after. Good afternoon and welcome everyone to the third webinar of 2023, supported by the ACCP Immunology and Transplantation PRN. My name is Stephanie Asechko, and I am a clinical pharmacy specialist in pediatric lung transplantation at Cincinnati Children's Hospital Medical Center, and it is my pleasure to be moderating today. Today's webinar is titled Pediatric Updates, Vaccines, and IPTA Congress, and we are honored to have both Dr. Staci Serluco and Gwen Nance serve as our webinar panelists. In a moment, I will turn it over to both of them so that they can begin our presentations, but first, just a few quick notes. So for our audience members today, please ensure that your microphones remain muted for the duration of today's presentation. The mute button is located in the lower left-hand corner of your screen. And at any point during the presentation, if you have a question for either speaker, please submit your question to me by using the chat functionality at the bottom of the screen as well. We will take all submitted questions at the completion of the presentation to minimize interruptions. Following today's webinar, it will be posted on the ACCP IMTR YouTube channel for your viewing. If you do experience any technical difficulties throughout the webinar, these could be fixed by logging out and refreshing your internet connection. And if that doesn't work, please make myself aware through the chat functionality as well. So without further ado, I will turn it over to both of our speakers. First up will be Dr. Staci Serluco. She completed her Bachelor of Science and Doctor of Pharmacy degrees from the University of Florida and her PGY1 Pharmacy Practice Residency at St. Joseph's Hospital in Tampa, Florida. Her PGY2 Pharmacy Residency in Solid Organ Transplant was completed at CHOA in Atlanta, Georgia. There, she currently works as the Solid Organ Transplant Pharmacy Specialist and also serves as the PGY2 Residency Program Director. Staci's presentation will be followed today by Dr. Gwen Nance. Dr. Nance completed her Bachelor of Science in Business Management from Purdue University and Doctor of Pharmacy from Stanford University McWhorter School of Pharmacy. Her PGY1 Pharmacy Practice Residency was completed at Children's of Alabama in Birmingham, followed by her PGY2 in Pharmacy Residency in Solid Organ Transplant at Children's Healthcare of Atlanta as well, where she also currently works as a Solid Organ Transplant Pharmacy Specialist. So Staci, feel free to take it away.
All right, thank you for this introduction. And give me just a second, there's a bit of a lag. So from today's portion of my presentation, I will be discussing updates on immunizations and pediatric solid organ transplantation and sharing some tidbits and pearls with everyone. I have no conflicts of interest to disclose in relation to today's presentation, and I will be discussing off-label use of one of the meningococcal B vaccines, Vixera, later on in my presentation. The objective for today's presentation are as follows. First, I want for you to be able to identify different immunization guidelines that are available that provide recommendations on how to vaccinate pediatric solid organ transplant recipients and candidates. We will also review some select vaccines that are recommended prior to and after pediatric solid organ transplant and discuss the implications of administering live vaccines to pediatric solid organ transplant recipients. To start off, I wanted to highlight a study that was published in JAMA Pediatrics that looked at almost 7,000 pediatric solid organ transplant recipients. And the study was looking at the incidence of vaccine-preventable infections in patients, in pediatric patients who underwent a solid organ transplant, and also looking at the morbidity, mortality, and costs associated with these vaccine-preventable infections. So out of almost 7,000 pediatric transplant recipients, 1,092 patients, which was 15.6%, had almost 1,500 cases of vaccine-preventable infections. And these infections were associated with increased morbidity, mortality, and cost among these patients. And some of the risk factors that were identified for vaccine-preventable infections were younger age, so patients less than 2 years of age were at an increased risk for developing vaccine-preventable infections, as well as recipients of heart, lung, and multivisceral transplant. So I think the study really highlights the impact of vaccines in pediatric solid organ transplant recipients, and also the complications that can arise when these patients are under-vaccinated. There are a couple of guidelines and resources that exist that provide recommendations on how to best vaccinate pediatric solid organ transplant recipients. Some of these are transplant specific and other ones are more general. So the first guideline that I wanted to highlight is the one from the Centers for Disease Control and Prevention, or CDC. These guidelines are updated on an annual basis. Usually CDC publishes its updated recommendations in collaboration with ACIP in February of this year. And these guidelines include recommendations for both routine childhood vaccines as well as for pediatric patients who may have certain conditions, such as those who are immunocompromised, who might have immunodeficiency, patients for sickle cell or asplenia, as well as patients with diabetes, are just some of the examples. The CDC guidelines also include, in addition to having a regular routine childhood immunization schedule, they do provide a separate schedule for kids with certain underlying conditions, like I mentioned, that might put them at risk for certain infections, as well as guidelines for how to catch up patients if they fall behind on their immunization schedule, and also fairly detailed footnotes with additional information on each vaccine. Another society that releases guidelines that include immunization guidelines for immunocompromised or cell organ transplant patients is IDSA. Their most recent guidelines were published in 2013, and they include recommendations on how to best immunize cell organ transplant recipients, as well as some other immunocompromised patients, such as those undergoing chemotherapy, bone marrow transplant patients with sickle cell and cochlear implants, as well as patients who take immunosuppressive medications, such as those with IBD. The IDSA guidelines also include recommendations for immunization of close contact. The third organization that has guidelines for vaccination of transplant recipients is the American Society of Transplantation, or AST. Their most recent guideline was published in 2019, and it provides recommendations specific to cell organ transplant recipients and candidates, and includes both adult and pediatric recommendations. And lastly, not necessarily transplant specific, but a good source for vaccine related questions is immunize.org, Ask the Experts. And this resource provides a lot of information on specific vaccines, as well as certain clinical situations. For example, what do I do if I have a patient who was supposed to get a 4-valent meningococcal vaccine, and instead of getting the reconstituted vaccine, they just got the diluent. So I find that reference to be very helpful. My apologies for the little lag in advancing the slides. Let's see. Okay. So for today's talk, we're not going to discuss every single pediatric vaccine, but instead we will focus on some select vaccines that oftentimes either require additional monitoring, serology testing, or additional doses, or are associated with clinical controversies in pediatric cell organ transplant recipients and candidates. So the first vaccine that we'll talk about is going to be the hepatitis B vaccine, followed by the human papillomavirus vaccine, meningococcal vaccines, pneumococcal vaccines, and we'll finish off today's talk by discussing live attenuated vaccines in cell organ transplant recipients. So starting off with the hepatitis B vaccine. This vaccine is usually initiated at birth and is typically given at a 3-dose series at 0, 1 to 2 months of age, and then again at 6 to 18 months of age as a primary series. For patients who are undergoing a cell organ transplant or being evaluated for one, it's recommended to follow either the routine or accelerated schedule if for some reason they have fallen behind on their hepatitis B immunizations. It is also recommended to obtain a post-vaccination hepatitis B surface antibody to assess whether or not patients have enough immunity. And that is recommended for patients who are either on dialysis, undergoing a cell organ transplant, or those with an HIV infection. The prevalence of hepatitis B non-immunity is actually fairly high, and they wanted to highlight 2 studies that specifically looked at hepatitis B non-immunity at different points during the transplant journey. So the study by Long et al., which was published in 2015, looked at 160 pediatric liver transplant patients at a single center who completed the primary hepatitis B vaccine series. And they looked at patients both who received the vaccine according to the standard schedule, accelerated schedule, and catch-up schedule. So all comers were included. In this patient cohort, the mean time to transplant was 5.6 years. And what the authors of the study found was that the majority of patients, 67%, who were previously immunized were non-immune at the time their hepatitis B surface antibodies were collected. And again, on average, that was about 5.6 years from transplant. And when looking at the univariate and multivariate analyses, the one common thing that was identified was the time from transplant was predictive of non-immunity. So the study tells us that regardless of what kind of schedule the pediatric patients receive their hepatitis B vaccine on, their immunity tends to wane after transplant and over time. The second study was by Ball et al., and the study looks specifically at pediatric SOT organ transplant patients at our center. So the study had 304 patients who completed their primary hepatitis B vaccine series. And looking at these patients, those who completed their primary series all of them had their hepatitis B surface antibody evaluated, and hepatitis B surface antibody was reactive in only 54% of the patients. It was indeterminate in about 3% of the patients, non-reactive in 39% of the patients, and was not available in 2.6% of the patients in this cohort. And this cohort included patients who were undergoing liver, heart, kidney, or combined cell organ transplant at our institution. And in terms of follow-up for these patients who were non-reactive, after additional vaccination, the hepatitis B surface antibody was found to be reactive in 33 out of the 45 patients in the study who received additional vaccine doses. So the response to additional vaccine doses was actually still pretty good in this patient cohort. Sorry, went a little bit too far. Let me backtrack a little bit. Apologies for this little technical difficulty. Okay, so what do we do when we encounter hepatitis B non-immunity? So the guidelines do recommend that we should target hepatitis B surface antibody of 10 or higher after completion of the primary 3-dose series. So in those patients who are found to be non-immune after 3 doses, we can do a couple of things. One is we can administer a second 3-dose hepatitis B series and then retest hepatitis B surface antibody in 4 to 6 weeks. Alternatively, and what we oftentimes do at our institution, just due to the time constraints, is that we will administer 1 dose of the hepatitis B vaccine and then retest hepatitis B surface antibody in 4 to 6 weeks after. And then if the patient still remains seronegative at that point, then we will administer 2 additional doses and retest if necessary. And one thing that I wanted to mention, specific to the pediatric population, because we do know that immunity can wane, it is important to consider repeating hepatitis B surface antibody and revaccinating after someone receives their transplant if it's indicated. So in those patients who might have received a kidney transplant are now approaching dialysis, or those adolescent patients who might be expressing high-risk behaviors and might be at risk for contracting hepatitis B infection. So moving on, the second vaccine that we'll talk about is going to be the human papillomavirus vaccine. Keep going. One of these times I will get it right, sorry. So with the hepatitis B vaccine or Gardasil, generally this is given as a 2 or 3 dose series. Typically your dose is initiated at around age 11 or 12, although you can give it as early as 9 years of age, especially in someone who may have a history of sexual assault or abuse. For patients who are initiating this vaccine prior to 15 years of age, it's typically recommended to give 2 doses, 6 to 12 months apart. For those who are starting it at the age of 15 or older, or if they have select conditions, as we'll talk about on the next slide, it's recommended to administer 3 doses of the HPV vaccine at 0, 1 to 2 months, and 6 months. All right. So oftentimes, what we see in our cell organ transplant patients after they receive their transplant, if they're of the age where they are receiving their HPV vaccine series, is that they actually are oftentimes under immunized. So with this particular vaccine, as I mentioned, if somebody started between age 9 to 14, they only need to receive 2 doses. However, that does not apply to patients who are immunocompromised. And for all patients who are immunocompromised, as defined by the set of guidelines, regardless of the age of initiation of this vaccine series, they should receive 3 doses. And the immunocompromising conditions would be things such as B lymphocyte antibody deficiency or T lymphocyte antibody deficiency, patients with HIV infection, those with malignancies who underwent a transplant, and patients with autoimmune conditions or those who are receiving immunosuppressive therapy. So thinking about patients who may have lupus, vasculitis, or IBD who are receiving immunosuppressive medications, those should receive 3 doses of the HPV vaccine, regardless of the age of initiation. And then for those whose series is interrupted, they do not need to repeat or restart the series again. All right, so that concludes our brief discussion of the HPV vaccine, and the next vaccine group that we're going to talk about are going to be the meningococcal vaccines. So there are currently 2 different types of meningococcal vaccines available on the market. The first type is the meningococcal conjugate ACWY or 4-valent vaccine. The brand names for it are Menveo and Menactra. So generally for patients who otherwise do not have high-risk conditions that put them at risk for encapsulated pathogens, this vaccine series is given as a 2-dose series. First, you get your first dose at age 11 to 12, and then you get your second dose between ages 16 to 18. For those who are starting this vaccine series at the age of 16 or older, a booster is a second dose, or a booster is generally not recommended. However, this vaccine series should be initiated in those patients who are at high risk, who have high risk conditions for developing meningococcal infections, and should be started earlier than 11 to 12 years of age. And those patients would include those with asplenia, both anatomic and functional. And I would say in practice, one thing to pay attention to are patients, pediatric patients with heterotaxy disorders, because oftentimes those might fall under having functional asplenia. Also patients with HIV infection, those who have complement component deficiency, so either genetic deficiencies in their C3 factors, C3, 5 through 9, factor D, factor H, or those who are receiving complement inhibitors such as eculizumab or ravulizumab. Also patients who might be traveling or residing in countries where meningococcal disease is either hyperendemic or endemic should start this vaccine series earlier. And when we start this vaccine series earlier, the minimum age differs between the 2 formulations. So Menveo can be given as early as 8 weeks of life, whereas Menactra cannot be given before 9 months of age. So for transplant patients and candidates specifically, you typically will follow the general recommendations for the 11 to 12 age group, unless your patient has any of these high-risk conditions for meningococcal infections. The second type of meningococcal vaccines that are available on the market are the meningococcal serogroup B vaccines. And so that would be Bexsero and Trememba. The general recommendation for this type of meningococcal vaccines is to do a 2-dose series in adolescents who are ages 16 to 23, if it's desired by the patient caregiver or at clinical discretion. So oftentimes, pediatric providers may recommend this vaccine series for those patients who are going to college and are going to be living in a dorm room setting. One thing to note, whereas with meningococcal ACWY formulations, Menveo and Menactra, the meningococcal serogroup B series formulations are not interchangeable. So if your patient starts their series with Bexsero, they have to finish it with Bexsero, and same goes for Trememba. However, with the serogroup B series, this vaccine is recommended for patients who are at least 10 years of age who have the presence of high-risk conditions for meningococcal infections. And again, those would be patients who have asplenia, either anatomic or functional, complement component deficiencies, or receiving complement inhibitors. And in this case, the dosing, the number of doses and the frequency is a little bit different. So Bexsero, you still complete a 2-dose series. Of note, and I wanted to bring this up, is that Bexsero is currently approved for age 10 years and older in the United States. However, it is approved in Europe and Canada for patients as young as 8 weeks of life. So at our institution, we do use it. We do use this early age cutoff for patients who may require this vaccine. And then for Trememba, this vaccine series for high-risk conditions requires 3 doses given at 0, 1 to 2 months, and 6 months. So just to summarize these slightly confusing recommendations in terms of meningococcal vaccines and specifically in transplant patients. So for your routine schedule, so this is for patients who do not have any of the high-risk conditions that can put them at risk for developing meningococcal infections. They should receive 1 dose of either Menveo or Menactra at 11 to 12 years, and then a booster dose between ages 16 to 18. And those 2 vaccine formulations can be interchanged if needed. These patients may also receive, if they desire, either 2 doses of Bexsero or 2 doses of Trememba, and these are the serogroup B vaccines. Now, for those patients, either transplant recipients or transplant candidates who have high-risk conditions, so either they have complement deficiencies and they're receiving things like eculizumab or ravulizumab, or they have asplenia, either anatomic, maybe they have sickle cell disease, or they have functional, they should receive the meningococcal ACWY primary series, which, depending on the vaccine formulation as well as the age of initiation, will consist of 2 to 4 doses. And I would encourage you to refer back to the CDC guidelines for the specific number of doses based on the formulation and age. And then these patients should also be revaccinated every 5 years because their risk for meningococcal infections will continue to exist. In addition to the meningococcal ACWY, these patients should receive their meningococcal B series, either consisting of Bexsero, 2 doses, or Trememba, 3 doses. And for those patients who are continuing to receive complement inhibitors, so maybe patients with atypical HUS who have to continue to receive their eculizumab post-transplant, revaccination is recommended with meningococcal B formulation 1 year after completing the series, and then every 2 to 3 years after, for as long as they stay on complement inhibitors. Okay, so that concludes our overview of meningococcal vaccines, and next we'll move on to pneumococcal vaccines. So recently, 2 new formulations of pneumococcal conjugate vaccines were added to the market. So in 2010, Prevnar 13 was added to the market and replaced Prevnar 7, which was and older formulation. And earlier in the past year or so, we had two different additional formulations get approved. The first one is Vaccinations, which is pneumococcal conjugate 15 vaccine that protects you from 15 different serotypes. And the second vaccine is the Prevnar 20 or PCV20. Prevnar 20 is only approved for ages 18 and older, whereas both pneumococcal conjugate 13 serotype and pneumococcal conjugate 15 serotype are approved for ages 6 months and older. So with the pneumococcal conjugate vaccine, either 13-valent or 15-valent one, typically it's given as a 4-dose series, and the CDC essentially considers them to be interchangeable. So typically you will receive this at 4, 6, 12, and 12 to 15 months of age. The minimum age, however, for starting this vaccine series is 6 weeks. So if you have somebody who could benefit from an early start and accelerated schedule in preparation for a transplant. One thing that I wanted to point out is that at least 1 or 2 doses will be needed for patients who either have chronic heart, kidney, liver, or lung disease, as well as those with nephrotic syndrome, patients who are asplenic, have immunodeficiencies, which will include HIV, sickle cell disease, and treatment with immunosuppression or radiation. And now we'll kind of discuss this implication on the next 2 slides. So the second available pneumococcal vaccine is the pneumococcal polysaccharide vaccine, PPSV23 or Pneumovax 23. This vaccine is generally recommended to be given to patients who are at least 2 years of age and have select medical conditions that put them at an increased risk for pneumococcal infections, such as chronic heart, liver, kidney, or lung disease. Those with nephrotic syndrome, asplenia, immunodeficiencies, which includes HIV, sickle cell disease, and those receiving treatment with immunosuppression or radiation. With the PPSV23, it's recommended to administer it at least 8 weeks after either PCV13 or 15. However, in those cases where patients may have received PPSV23 first, it's recommended and need additional doses of PCV13 or 15, it's recommended to administer the pneumococcal conjugate vaccine at least 8 weeks after the PPSV23 dose. For cell organ transplant recipients and those with the select medical conditions, it's recommended to revaccinate 5 years after the first PPSV23 dose. Okay. Again, wanted to highlight a study that looked at the incidence of pneumococcal infections in immunocompromised children. So this study looked at cell stem transplant patients, cell organ transplant patients, 18 years of age or younger who developed invasive pneumococcal infections. And the study period was quite large. It was from January 1st of 2000 to December 31st of 2014. During the study period, 65 cases of invasive pneumococcal infections were identified. And out of those 65 cases, cell organ transplant recipients represented 68% of the cases, so 44 out of the 65 cases. Among the cases identified, bacteremia and pneumonia were the most common infections in those patients. And then overall, the authors noted that the pneumococcal immunization rates were extremely low in this specific patient population. So what can we do to kind of help improve immunization rates? So as pharmacists, I believe that we can play a vital role in ensuring that our patients stay up to date on pneumococcal vaccines, especially since the vaccine recommendations for this particular vaccine type are a little bit different than the general population. So the guidelines currently recommend that for all patients, outside organ transplant recipients or candidates who are under 24 months of age, they should receive 4 doses of Prevnar 13 or 15 or Vaxneuvance, which is the 15-valent one, regardless of their age or time of initiation of these vaccines. So for those recipients or candidates who are 2 to 5 years of age, if they received less than 2 doses of the pneumococcal conjugate vaccine before 2 years of age, they need to complete 2 additional doses, followed by Pneumovax 23 or PPSV 23, 8 weeks after their most recent pneumococcal conjugate vaccine dose. If the patients between ages 2 to 5 receive 3 doses, then they only would need 1 additional dose, followed by Pneumovax 23 8 weeks later. And then for those who received all 4 doses, they would only need Pneumovax 23. So again, the goal for patients up to age of 5 is to complete 4 doses of either the 13-valent or 15-valent pneumococcal conjugate vaccine. And then for those candidates or recipients who are at least 6 years of age or older, it's recommended that if they have not had any pneumococcal conjugate vaccines, for them to give 1 dose. If they had at least 1, then they can proceed straight to Pneumovax 23. And then for all patients receiving Pneumovax 23, they recommend to revaccinate in 5 years. And lastly, I wanted to briefly highlight the new development in live attenuated vaccines for cell organ transplant patients. So generally, when it comes to live vaccines, the pre-transplant approach should be to try to optimize these vaccines and administer them at the first pre-transplant visit to pediatric patients. That MMR and varicella should be administered at least 4 weeks prior to planned transplantation. And then for patients who may not be old enough to complete this vaccine series according to the routine immunization schedule, we should consider initiating MMR and varicella vaccines at 6 months of age. And generally, live vaccines were thought to be contraindicated post-transplant until recently. So in 2018, there was a consortium of transplant physicians that came up with consensus recommendations regarding live vaccine administration after pediatric SOT organ transplant. And I wanted to review a couple of things from this particular set of guidelines. So first, these physicians kind of discussed maybe the paradigm shift in terms of our thinking about live vaccines post-transplant. So generally, they recommended to defer vaccines for those patients post-transplant who are not clinically well, had recent rejection episodes, require high levels of immunosuppression, receive novel biologic agents, or those who may have immunodeficiency or have undergone a heart-lung or multivisceral transplant. They also discussed that we should maybe consider vaccinating patients once we receive informed consent. Also if we do decide to start a live vaccine program, to have an active and passive surveillance mechanisms for any adverse effects, and then consider doing 2 doses of the varicella vaccine, and then post-vaccination serology to help determine how many MMR vaccine doses the patient would need. And so this 2018 consensus guideline also outlined the proposed eligibility for patients. So they kind of broke down their guidelines into 3 groups. Group 1, those who would defer a vaccine, and those would be patients who received alemtuzumab, ATG, or rituximab in the past 1 to 2 years, depending on the agent. Patients who underwent a cardiac, lung, or multivisceral transplant, those are not clinically well, who receive high levels of immunosuppression, or novel biologic agents. So those are not candidates for your live vaccine. Then they also discuss patients who might be good candidates for live vaccines. So those would be your liver or kidney transplant patients who are at least 1 year post-transplant and 2 months post-rejection. Those who receive fairly low levels of immunosuppression, so steroids less than 2 per kilo or less than 20 milligrams per day, with tacrolimus levels less than 8, or cyclosporin levels less than 100, and also who meet certain immune criteria based on their ALC and CD4 counts, and also those who have normal IgG levels. And lastly, they also discussed that there might be some patients that we could vaccinate, but we have to proceed with caution. So those who are receiving mycophenolate, as well as those who might have received either T cell or B cell depleting agents, but in a shorter time frame than what's discussed in group 2, those who they think are safe to give live vaccines to. So in conclusion, for this overview of pediatric SOT organ transplant immunizations, the pediatric transplant recipients and candidates are generally at increased risk of vaccine preventable infections. So we should make all attempts to help immunize these patients early in their disease course and to ensure that they're able to mount adequate immune response prior to initiation of immunosuppression. Also, pediatric SOT organ transplant recipients may require additional vaccines and doses, such as in hepatitis B vaccines or pneumococcal vaccines. And lastly, administration of MMR and varicella vaccines may be considered for select SOT organ transplant patients, such as kidney patients or liver patients on low levels of immunosuppression. And with that, I will transition to Gwen.
Okay. All right, so today I'm going to talk about highlights from the 12th Congress of the International Pediatric Transplant Association. And so as I was preparing this presentation, I found it really difficult to select only a few topics to discuss in this kind of 15 to 20 minute presentation when you're looking at 4 days of interesting and educational information. So I really decided just to approach it in a way that would be useful. So I wanted to give you information on relevant and applicable topics that you can use in your everyday work life. So today, the topics we're going to discuss involve the impact of a transplant pharmacist, the use of belatacept in pediatric patients, subcutaneous administration of IgG for AMR, and novel treatments for rejection. Oh, here we go. Okay, sorry. So as pharmacists, we already know, and I mean, really all of our providers know just how valuable we are as a member of the multidisciplinary team and how we can have a significant impact on our patients. We also know that there never seems to be enough of us. So many of us are spread thin. You know, we're covering inpatient and outpatient. We might be covering multiple services. You may be involved in clinical on-call or weekend rotation, et cetera. And if your institutions are similar to those that I have had experience with, you are very aware of how difficult it can be to attain additional pharmacist FTE. So anytime that I see data presented on the impact of pharmacists that the pharmacist can have, I really try to make a note of it. So these can be used in proposals for additional FTE, or they can even be a place to start when you're trying to assess maybe your own impact or collect your own data. The group from MUSC and Dr. Tombly presented 2 studies on pharmacist impact. The first of these studies was the clinical impact of transplant pharmacists on medication management in outpatient pediatric transplant clinic. The goal was to attain, their goal really was to attain additional pharmacist FTE. Their institution only has 1 pharmacist that covers both liver and kidney, both inpatient and outpatient, also covers nephrology, And then I think is also involved in the weekend coverage rotation. So really, they need and would like to have some additional support. They looked at a 6-month retrospective review where they had 126 kidney transplant clinic visits. They had clinic 1 day of the week. The pharmacist was able to be present at 67 of those visits, so 53%, which would make sense if that pharmacist is 0.5 FTE for kidney and 0.5 FTE for liver. At all of the 67 visits the pharmacist was present at, they were able to perform 100% of the medication reconciliations for those patients. And although they didn't really quantify it, like we all know that doing a medication reconciliation, you can find so many things that could potentially may need intervention just with that one particular thing that we do. For them, they did look at 4 specific things. So if the pharmacist recommended a dose change, if they recommended vaccines, a new medication, or if they made sure that recommended refills so that the patients didn't run out of medications. And as you can see, at 30% of the visits, pharmacists recommended dose change, 31.3%, they recommended vaccines, and 16.4%, they had new medications, and 30% of those visits, they needed to make sure that refills were available for patients so they did not run out of medication. So their conclusion was that transplant pharmacists play an integral role in the pediatric kidney transplant multidisciplinary teams. Through pharmacist intervention, they have improved vaccine rates, medication monitoring, and dose accuracy. They currently are looking at the cost savings that are associated with these interventions, and so more to come on that. The second study that they presented was the impact of pharmacy-driven vaccine program in abdominal organ transplant patients prior to transplant. Their vaccine program they established in 2019. Their process is that the pharmacist does an assessment of and makes recommendations for vaccines at the time that the patient is referred, or basically at their evaluation. They compared the number of CDC recommended vaccines that that patient had at time of eval, and then how many they had at time of transplant to evaluate kind of what their impact was with the program. So in their kidney transplant group, 81% were vaccinated, or I guess average 81% were vaccinated, but none of the patients were actually completely up to date on vaccinations at time of evaluation. At time of transplant, though, 97% were vaccinated, and of the patients, 53% of them were up to date on their vaccines. So they found that on average, they gave 5 vaccines, so anywhere up to 12 vaccines per patient, and that those were given between referral and time of transplant. Their average time was 280 days. On their liver transplant side, 79% were vaccinated with none up to date, again, at time of evaluation. At time of transplant, though, again, 97%, so 91 to 100% were vaccinated, with 43% of those up to date. They gave approximately 7 vaccines per patient, so anywhere from 1 to 15 between referral and time of transplant, which was approximately 264 days. The majority of the vaccines that were kind of missed or were missing so the patient couldn't be considered up to date were typically the live vaccines for some patients. So in this study, they concluded that the pharmacy-driven vaccine program greatly improved our vaccination rates prior to transplantation in both the liver and kidney transplants. They also found they're also able to identify some of the barriers that exist in making sure that all of these patients get their vaccinations. So one major thing is that a lot of primary care physicians feel uncomfortable giving vaccines to patients that are transplant. They just kind of are a little bit hands off, and they want that to be controlled by a transplant team. The other main thing was that a lot of the patients didn't actually have a primary care provider. So I think you guys are probably familiar with how patients, they come back and see subspecialties so frequently that they end up sort of using that subspecialty as their primary care group, although they should still have a primary care physician. And then also at pediatric primary care physicians, offices, they typically don't carry Pneumovax since there's really not a large number of patients that pediatric patients that have indication for Pneumovax. Those boxes typically come in like 15 to 20. And so they aren't really going to use all of those. So they don't typically have them. So next we're going to talk about belatacept use in pediatrics. So I'm sure the majority of the people on here are familiar with our selective T-cell co-stimulation blocker belatacept. It binds to the CD86 receptors on the antigen presenting cells to block their interaction with the CD28, which is what's needed to activate the T cells. We know that from adult studies that belatacept is associated with reduced de novo DSA, improved renal function, and prolonged allograft survival in adult transplant recipients. For adults, there is a lot of data, and I think there's a lot of comfort with using this particular agent. However, on the pediatric side, we really have limited published data on the use of belatacept in patients. So during IPTA, there were 2 different presentations on belatacept use in pediatrics. The first of these was from Dr. Sanchez Vivaldi from the University of Texas Southwestern Medical Center. His group wanted to assess outcomes of pediatric transplant recipients who were converted to belatacept-based regimens. They had 18 patients with a median age of 12. Rejection or non-compliance was a primary indication for conversion. However, they did have 3 patients converted because of CNI toxicity, 2 additional patients converted for worsening renal function, and they had 1 patient that was converted because they were having MMF toxicity. What they found is that there was a high compliance rate with monthly infusions. During the 6-year study period, patient survival was 100%, while graft survival dropped to 89% with the loss of 2 kidneys. In 13 of the 18 patients, GFR was preserved, and in those converted for CNI toxicity, they did see an improvement in renal function with no rejection that was observed. In this group, they did have 3 patients that had to switch back to calcineurin inhibitor-based regimen. 1 of them was for rejection, 1 of them was for transportation issues, and then 1 of them was for COVID-19 infection. When they looked at donor-specific antibodies, 10 of the 18 patients had no DSA prior to conversion. And of those 9 of the 10, so of those 10, 9 of them continued to have no DSA after conversion. 8 of the 18 were DSA positive prior to conversion. 1 of those 8 did become DSA negative after conversion. So their conclusion was that there's a high compliance rate with belatacept infusions, and that this is potentially gives us an effective option for recipients with higher rates of non-adherence. The second study looking at belatacept was from France. So they wanted to report outcomes of 18 pediatric patients that were from three different pediatric nephrology departments in France who were converted to belatacept. So the maintenance immunosuppression that these patients were on was typically a calcineurin inhibitor, an antimetabolite, and a steroid. There were 6 of them that were steroid-free though. They monitored monthly CMV and EBV surveillance. They had a biopsy pre-conversion and a biopsy 6 months after conversion. To convert to belatacept, they started with a dose of 5 mg per kg every 2 weeks for 5 doses, and then went monthly, again at the 5 mg per kg. Tacrolimus was reduced 25% each visit, and so it was stopped after 2 months. The antimetabolite dose was increased or really optimized at CNI withdrawal. So what they found was that CNI, they were able to withdraw CNIs from 17 to 18 patients. GFR was stable or improved over a median time of follow-up time of 12 months. Rejection episodes were observed in only 4 of the 18 patients. However, 2 did need to have CNI reintroduced. There was no development of de novo DSA. 4 of the 18 patients had pre-existing DSA, and that actually just remained stable after conversion to belatacept. So their conclusion was that selected pediatric transplant patients may benefit from long-term CNI toxicity avoidance, but the selection criteria need to be kind of more refined to avoid rejection episodes under co-stimulation blockade. And then this was just a graph looking at each of their 18 patients and their GFR over time. So you can see that it stayed relatively stable, maybe a little bit of an increase for some, but basically no change. So next I want to talk about immune globulin G. So it's a product that we're all very used to. It's commonly used in our post-transplant patients for rejection. However, we typically or primarily administer it intravenously, which has to take, if you're doing this outpatient, it has to take place at an infusion center. You may have to admit the patient to give them their dose of IVIG. So it can lead to a variety of different issues, making this method of administration cumbersome. It also requires a significant amount of time, and it can be extremely costly. So I know that at our center and with my providers that the question of subcutaneous administration is commonly brought up, but in general, it just sort of like mentioned and then generally not pursued. And some of that is that its use isn't well documented in pediatric transplant. So this group looked at, they did a retrospective chart review to assess the efficacy and tolerability of sub-Q IVIG, sub-Q IG in pediatric kidney transplant recipients that were treated for antibody-mediated rejection. So they used a dose of 0.5 gram per kg per month. That was divided, and the doses were given twice weekly at home. So their first patient had a mixed AMR and ACR, and then they also developed after treatment with the whole gamut, everything. They did have BK viremia and persistent DSA. So they decided to use the sub-Q IgG. What they saw was that BK viremia resolved, DSA and GFR sort of stabilized, and has continued to remain stable with the continued use of sub-Q IgG. For their second patient, this patient had a severe AMR, where again, they got treated with everything. But even after that, they still had increasing DSA. So after starting, so they decided to start the sub-Q IgG. DSA and GFR were stabilized, and that was from 2018 to 2001. That was when that patient ended up needing to start dialysis. For patient number 3, again, AMR, treated with all the things, but they ended up having recurrence of DSA after treatment. So they utilized, again, sub-Q IgG, and what they saw was resolution of their DSA. So kind of the conclusion from this is that patients didn't report any infusion reactions. Many of them actually preferred having home administration. The insurance approval was able to be obtained for all of the patients. Parents administered twice weekly sub-Q IgG therapy, and that was well tolerated, and it could be an effective alternative to monthly IgG therapy for some patients. It's 2, do I keep going? Okay. Lastly, so the last kind of thing that we're going to talk about are just some novel modalities for intractable rejection. This was a talk given by Dr. Zhang, who's the medical director of intestinal transplant at Stanford Children's Health. The therapeutic targets that were sort of focused on were for refractory cellular rejection. So we're talking about extracorporeal photopheresis, also, sorry, blanked for a second. Also, sorry, JAK inhibitors, and then lastly, there's some exome therapies that are sort of up and coming. So for extracorporeal photopheresis, really most of the data is in adults. This therapy is an immunomodulatory therapy where you isolate leukocytes and then you prime those for UVA radiation that causes apoptosis of the white blood cells by UVA radiation. The antigen presenting cells phagocytose the apoptotic cells, and you end up with an anti-inflammatory response, and then you get Tregs suppressing effector T cells. Or at least that's the most accepted thought of mechanism behind photopheresis. There's still a lot of studies and things that are unknown. So again, most of the data is in adults, and they're, primarily it's actually primarily an adult heart transplant. From that data and from the experience that Stanford has with their pediatric patients, there were minimal side effects. So the Stanford experience, they had 3 intestinal transplant patients that were treatment refractory ACR. They've been treated with steroids, infliximab, kind of all the things again. And so they decided to treat with ECP. They ended up, the patients ended up having resolution of rejection. So in all of them, over a 12 to 16 week course. They were also able to wean steroids or withdraw steroids in all of the patients within 4 weeks of ECP initiation. So kind of some promising things there. In their liver transplant group, they treated 4 patients with ECP. All 4 of those patients had resolution of rejection, and all over a longer time period, though, for the majority of them, it was kind of a range from 4 to 48 week courses. With ECP, there of course are always going to be some limitations. So standard protocols for treatment, there's not a lot out there. So there is the American Society of Apheresis or 2019 guidelines, where they are sort of recommending 2 consecutive days weekly for multiple months. In addition to that, ECP is not cheap. It has a very high cost to each session, so it can be more than $1,500 per session. And then there's really more need for identification of pharmacodynamic effect. The next kind of novel thing that's coming are JAK inhibitors. So they inhibit JAK enzymes that restrict intracellular growth factor and cytokine mediated signals to prevent inflammatory response. We are really just beginning to understand JAK inhibitors and their potential use in SOT, but they do play a critical role in cytokine cell signaling and tend to have effects that are restricted to the immune systems, your TB and natural killer cells. All drugs are good, but they also have adverse effects. Adverse effects include infection, hypertension, anemia, rash, gastroenteritis, and diarrhea. One important adverse effect to note is that there was a significantly higher incident of viral infections, so CMV, EBV, BK, and viral malignancies, specifically PTLD, when JAK inhibitors were used in combination with MMF. The standard experience that they have with JAK inhibitors is, so from these graphs, you can see that the measured GFR, so the first one, the measured GFR at 6 months and 12 months in the ofacitinib group had a higher GFR than the cyclosporine group. For the chronic allograft nephropathy, which is our second chart there, the tofacitinib groups had less CAN at 12 months compared to cyclosporin. The difference between those two groups, the dark purple and the striped purple, was actually the dose of ofacitinib that they received. So the dark purple had a lower dose had a higher dose, and then the striped purple had a lower dose. And then lastly, exome therapy. So exomes are these small lipid bilayer vesicles that are naturally produced by stem cells. They are used to deliver therapeutic molecules to specific cells in the body. So they primarily exert their effects, their immunomodulatory effects through growth factors. And they're really isolated from human stem cells. So that gives them a lot of advantages. So they're not stem cells. They lack replicating potential. And so there's a lack of malignant transformation, lack of immunogenic response. And then in all of the patients that have received exome therapy, 0 patients have reported toxicities or side effects. So for exome therapy, there is no current FDA approved product. Exome therapy was actually initially used in treatment of ARDS and COVID-19 adult patients. But the FDA has moved to allow INDs for other applications of exomes. So at Stanford, their experience, they have had 5 liver, 2 multivisceral, and 2 intestinal transplant patients that they have used exome therapy on. Exome therapy is an IV infusion, and they get 3 doses per cycle. And they have seen a complete resolution of rejection with 3 doses, so just 1 cycle of the exome therapy. Okay, and that's it. Thanks, guys. Sorry, I went a little over.
All right. Well, awesome job, Staci and Gwen. Thank you both so much for sharing all of that great information. Yes, we are a little bit over time, but if anybody has any questions, please feel free to unmute yourself. I did not get any in the chat, but if you have any last minute burning questions now that you want to ask, please feel free to do so. All right, and being that there isn't any, I think we will go ahead and end, but thank you all so much for joining, and we will see you next time. All right, thanks guys.